Hi, this is Menorrhagia, and here is another podcast on Obstetrics and Gynaecology, and this time the subject is Menorrhagia. So the learning points for this podcast is the definition of Menorrhagia, the causes, history and investigations, and we'll also talk a little bit about the treatment. So how do we define Menorrhagia? Basically, Menorrhagia is a very heavy period. Now, this is often subjective to the person who is experiencing the period, but you can also say it is blood loss over 80 millilitres or bleeding for greater than 7 days. It is a very common gynecological problem. So let's look at some of the causes of Menorrhagia. So with a regular cycle, which is painless, some of the causes are fibroids, which are also known as leiomyomas. These can increase the surface area of the endometrium and hence cause increased bleeding. Dysfunctional uterine bleeding, which often occurs in young girls, where you don't get the usual cyclical response and the estrogen dips in the menstrual cycle, and so often you get proliferation of the endometrium and increased bleeding. Coagulation disorders, such as von Willebrand's disorder, where you get a disorder in the platelets and increased bleeding. And also in older ladies, endometrial carcinoma and endometrial polyps. Menorrhagia, where there is a regular cycle, but the period is painful, i.e. there is dysmenorrhea, can be caused by pelvic inflammatory disease, which is infections of the uterus such as chlamydia and gonorrhea. Additionally, endometriosis, where there is implantation of the endometrium outside of the uterus, and adenomyosis, where the endometrium implants in the myometrium. Additionally, also intrauterine devices, such as copper coils, can also cause menorrhagia and dysmenorrhea. Causes of menorrhagia where there is a short cycle but excessive menses, also known as epimenorrhagia, can be due to ovarian dysfunction. Additionally, as we talked about in previous podcasts, amenorrhea, or irregular cycles such as oligomenorrhea associated with excessive menses, can be due to thyroid disease, and this is more associated with hypothyroidism in menorrhagia. If there is a long cycle and excessive menses, this can be associated with prolonged continuous use of combined oral contraceptive pills. So, history is really important when trying to find out the cause of menorrhagia. You often want to ask the patient, when did their period start and what age? Were their cycles always irregular or regular? How many days does their cycle last? In terms of the actual menorrhagia, you can find out how much bleeding they're experiencing by asking how many times they change their tampon or pad a day. Additionally, you can ask about incidents of flooding and excessive clot production. You also want to ask if the period is painful or not painful, so are they experiencing dysmenorrhea? Additionally, intermenstrual bleeding can indicate causes such as endometrial carcinoma and endometrial polyps. Are they experiencing postcoital bleeding? Because that can indicate that they may have pelvic inflammatory disease. Is their heavy bleeding now impacting on their lives? So ask about symptoms of anemia, such as chest pain and breathlessness. What kind of contraception are they using? Are they using the oral contraceptive pill without a break, which can cause a very long break between cycles and excessive bleeding? Or are they using things like the copper coil, which can cause menorrhagia? You also want to ask about PID symptoms, such as pelvic pain, fever, vaginal discharge. Additionally, I also mentioned the recent coil insertion before. Ask about pressure symptoms on the bladder and bowel. This can be indicative of fibroids, for example. And ask about any family history of coagulation disorders. So moving on to examination, do they have any clinical signs of anemia? Are they conjunctiva pale, for example? You then also want to move on to abdominal and bimanual examination. This is important when you're trying to feel for any masses, any fibroids, etc. A speculum exam is important as you want to do a smear test. Although cervical carcinoma is not associated with menorrhagia, it may present with excessive bleeding. Additionally, you also want to do endocervical and high vaginal swabs to swab for any chlamydia and gonorrhea. You also want to do some basic bloods, so do they actually have anemia? So just do a full blood count, measure their clotting, and do thyroid function tests. You can do a pelvic ultrasound to measure the endometrial thickness, and this may also show fibroids and polyps. If you suspect there is something wrong with endometrium, you can do endometrial sampling, and a hysteroscopy allows you to look further into the uterus. So what is the treatment? There are 3 different forms of treatment that you can have. Now, conservative treatment is just supporting information about the condition, and a lot of women actually respond to this and realise that their condition isn't dangerous in any way. If you want to go on to further help the woman, you can do medical treatment, and this can be non-hormonal or hormonal. Now, in a lady who is premenopausal, who is still trying for children, a non-hormonal approach may be more appropriate. For example, using NSAIDs such as mefenamic acid and ibuprofen. These often reduce the bleeding and dysmenorrhea by inhibiting COX-1 and 2 enzymes, and so decrease prostaglandin formation, which decreases the amount of bleeding. Additionally, you can use antifibrinolytics such as tranexamic acid. These inhibit plasminogen activator, which is one of the enzymes which decreases clot formation. They both have side effects on the gastrointestinal system. So moving on to hormonal treatments, the combined oral contraceptive pill has been known to reduce menorrhagia and also reduce bleeding time. This also gives the added advantage of being a contraceptive. Additionally, women who are slightly older, you can use the progesterone-releasing intrauterine system. This is different from the copper coil in the way that it actually reduces bleeding and provides a form of contraception. If the lady does not want a coil insertion, then you can also use progesterone orally or by depot injection. Additionally, you can move on to more complex hormonal treatments such as gonadotrophin-releasing hormone analogues, such as goserelin. These increase GnRH levels and so decrease the negative feedback in the hypothalamic pituitary system. This leads to a decrease in estrogen production. If a lady doesn't respond to medical treatment and is not of childbearing age, then you can consider surgical treatments such as endometrial ablation and hysterectomy. If she has fibroids and you think that is the cause of menorrhagia, then you can do a myomectomy, which preserves fertility but can also remove the fibroids at the same time. So in summary, this is a common gynecological disorder. There are varied causes, but most are actually benign, and you can have 3 different forms of treatment, which we discussed earlier: conservative, medical, or surgical.